we'll be just sharing. The protocol is already there. I am sure all of you might have read it, have understood it, because it is not that difficult as it was in 2018, because we are so familiar with managing COVID-19. So when we talk of Nipah, I think I should not forget this slide, and we should begin with the remembrance of Sister Lini, and that has given a very big message what a healthcare worker should be. And it's really giving motivation to all the healthcare workers during COVID and now in this current situation in Kozhikode. So I was just remembering them, and so I'll just give you an overview of the outbreak, and I'll put a few slides of 2018 and one slide on 2019, one slide of what is happening now in Calicut. And we know the clinical presentations. We are very familiar with the presentations because we know that some of the syndromic presentation in emergency department or in casualty, we should be alerted that this could be Nipah. But it is not at all easy to suspect when you have a busy casualty and identify which patient could be Nipah. And there are management concerns. What is the infection control practices that we should adopt? What are the lessons learned? And we are also looking for the long-term sequelae. And we were not sure because very few patients were there, but there are sequelae reported in some of the previous studies. But now we know very clearly what is the sequelae, because we always talk about post-COVID. So maybe if you have seen more number of patients, we may also be seeing in this also. So this is just to give an overview why I said it, that it is not easy to detect. This is the situation in most of the medical colleges and most of the district hospitals. We see so many patients beyond the capacity that we could manage. So this gives us the importance of emphasizing, especially after COVID, how to prevent infections within the institution, and hospitals should not be acting as a focus for spreading the infections. So, but this time there was a lot of difference compared to 2018 because of COVID, everyone was using masks. Hand sanitizer and sanitization use was very much prevalent, and gloves was there. So this might have protected to a larger extent because our red area is usually we have more patients than we could accommodate. We should not be doing in COVID times, but it happens sometimes in a busy medical college. So this is the important point that I would like to emphasize, and we should discuss and design protocols that can be adopted in wherever we practice, because the situations in different institutions or different hospitals are different in Kerala. So this has to be done. And now we have identified as the COVID Nipah facility, but we don't know any of the primary care center, district hospital, or all of these institutions may be facing such challenges, because this patient also, when we go back and take the history, patient has gone to a primary care provider practicing, and then patient has gone to two smaller hospitals, then came to medical college, and then came to the third hospital. So this happens in most of the situations. So we all must be prepared to tackle this sort of outbreaks or episodes so that we could try to minimize the harm maximum to the society. Outbreaks are not unusual, but situations like this, zoonotic outbreak with high human to human transmission, we need a lot of preparedness. So this is what is very important. And COVID has given us some of the lessons, but we know that using a proper mask and hand sanitizing usually protects to a larger extent in spreading the COVID from most of us. But we know that Nipah is more infective compared to COVID because it is there in respiratory secretions, but other fluids as well. So this is how it is different from COVID. And situation suddenly changes if something like this happens. But interestingly, what it was Calicut when Nipah was identified in 2018 is quite different, because people are more confident and the crowd is not as much reduced as it was in 2018. So I'll just give summary of these cases so that we will know how to look at these cases when we really see in the clinical practice. So this was the first case. This is a 26-year-old male. He came to the casualty with high-grade fever, headache, vomiting, altered sensorium. He was febrile, he was drowsy, tachypneic. He was in the emergency department itself. He was managed, and he has features of ARDS encephalitis. And on the same date, he expired. So this is like any other viral encephalitis, and this patient expired, and we had the diagnosis it is viral encephalitis, but we have been not we have been not tested for this sort of exotic or this sort of infection that cause human to human transmission. So this is what has happened, but it became turned out to be very interesting because more family members affected and people related to or in the same hospital facility affected, and that is how the system alerted. So always we must remember that it's very difficult to identify with the first case itself, but there are some peculiar features that will tell us this could be Nipah, or it could be something like sort of encephalitis like autonomic instability, brainstem dysfunction, eye movement abnormalities, nystagmus. All those things might give us a clue, but usually it happens towards the second week after 7 days or 6 days or so. So by the 6 days, patient might have visited many facilities. So my message is any viral encephalitis, we need to be more cautious, and I think we should not give up the practice of using mask and gloves and sanitizers while seeing the patients, because we never used to do this in previous days. So the clinical profile of an Nipah virus infection, incubation period is on an average 4 to 14 days. Food bats of Pteropidae family is identified as the intermediate host. So the bats actually, they are not getting infected, but in Malaysian outbreak, pigs were considered as the intermediate host. And as far as I could understand, a very few outbreak with horses as the host in between. There is no other animal has been considered as intermediate host, but fruit bats are harboring this virus, and there was studies done at that time, and it was shown that most of the belts in Kerala up to Maharashtra is harboring this sort of bats, and the bats has been identified to have this Nipah virus. So we need to be cautious, and that classical symptomatology, the triage in an established case will be encephalitis, ARDS with myocarditis or without myocarditis. And I have already told it's a BSL, it's a human to human transmission, and we need BSL level 4 lab facilities for identifying and viral culture and all those things. And what we need to do is we need to be very careful about the infection control practice, isolation, intense supportive care, and we have to have the action plan in such outbreaks. When it happens, we need to have more focused, and we need to work as a team in managing such sort of outbreaks. So this is the slide I have just put because not like other illnesses, other infections, we cannot manage Nipah at one hospital or one district alone. The entire system has to be alerted, and the response should be at the hospital level as well as at the public health level. And we need to enhance, because now we are more trained because of the COVID outbreak that has happening as a pandemic, and this sort of action or activity is very well happening in Kerala with such a good public health system happening. So when we talk of the Nipah virus infection, I have already emphasized, I am putting some of the points again. We need to emphasize and maintain strict infection control practices. And the institution infection control team should ensure proper use of personal protective equipments by healthcare worker. We feel that all of us are trained in PPE use, but with vaccination, and we know that it's not that serious, COVID-19, there is a laxity in using PPE, and this might have caused some of the issues in our own institution. We need to re-emphasize or retrain and how to use PPE in this situation, and this has to be emphasized because once in a while, maybe once in a year or once in 2 years or once in 3 years, we might be seeing such outbreaks. But if we do it correctly, further damage or further spread of infection within the institution and hospital facility we can avoid. And And the other important point I would like to emphasize is housekeeping practices. We should be, the sisters and nursing team should be very much trained about seeing how to do it properly. And the staff health monitoring is very important. We are doing even now with the COVID-19. And whenever a person comes with fever, it is always prudent that we should not be asking them to work. We should remove them, all our sick people, from the work site, and implement strict visitor policy. This is also we are implementing. And safe collection and handling of samples, and strict adherence to protocol of handling disease. So these are some of the very, very important points when we have an infection of this sort with human to human transmission and high mortality. We need to handle it with so very careful. Lab diagnosis. It is very important to confirm Nipah before we send samples for other purposes like complete blood count. We'll be tempted to do investigations like blood glucose, blood urea, creatinine, but I've already emphasized the blood and urine and serum samples all will be containing the virus, and we are growing virus from this sample. So we need to emphasize that these samples are properly collected, properly transported, and if at all we are sending a sample to any institution, our laboratory, we need to inform them prior so that the lab people will be protected. So we should not be testing other investigations. We should not be sending other investigations. If we really suspect Nipah, we need to rule out. And the test that we do is real-time reverse transcriptase PCR, and it is being done in as a point of care test in our own institution. But I will tell you how it is being done now in Calicut Medical College. But we are we must be ruling out other causes, because more than Nipah, even in those who are healthcare workers or those who are contacts, we are getting admitted with symptoms. Most of them are getting tested for COVID-19. So we have to rule out. Now it is a major challenge, because when we put a patient in the person in the contact list, what we are asking is symptoms, and symptoms are the same for COVID-19. So this is a major challenge. So we need to rule out other causes of fever, and we need to find out a solution for testing other investigations when we have to handle such a situation in our hospital. So this is I've just put for the fun, because it was so very challenging at that point of time, and now I know that these are very imperfect slides, because it has changed a lot in 2020 and 2021 with the COVID outbreak, and all of us have really more trained in using PPE. So this I have already discussed about 2018 outbreak. One in text, we had 18 confirmed case, and probable cases for, and clinical presentations were encephalitis, ARDS, or myocarditis. And one patient had only fever, headache, and tiredness, like an upper respiratory infection. And I must also say one patient came with an upper febrile illness alone, because we are really continuously focusing, and he was in the contact list. After that, he turned into test positive. So this I would like to emphasize, if we really think that this person has got a high risk contact, and patient is having symptoms, and if our initial test sample is negative and continuing symptoms, ruling out other causes, always we should send a repeat test for Nipah virus infection, even if the first sample is negative. And in Kozhikode outbreak, among this, we had 2 survivors, but the survivors were having different spectrum. One was having myocarditis, encephalitis, ARDS, and dysautonomia, but the other was having a simple flu-like illness with fever and fever, cough, and cervical adenopathy. So this is a very wide range of spectrum, but only 1% patient has a milder symptoms. All others had severe symptoms, and only 2 were survived out of this outbreak. So this is just to show you how these clinical manifestations we have seen, because this I have listed because we need to know how these patients coming to the emergency department. So all of them, in those 12 cases that have come to the emergency department, this is what we have seen. The median incubation period was 11 with a range 8 to 15, and duration hospital case in fatal cases was 10, and these are some of the important findings. But I would like to share this slide more important. We need to know that these are the cases came to directly to the emergency department. We know that 12 were the total number, 100% had fever. So it is always unlikely that if a patient comes with headache and altered sensorium, headache and vomiting, unlikely that it's a viral illness of this sort. So we must always get the history of fever. And even if the patient comes with altered sensorium or headache or vomiting, and they say no fever, we need to document that there is no fever, because sometimes these patients will be having fever. So history of fever is very, very important. Other symptoms are almost the same that we expect in any viral illness, like vomiting, headache, cough, breathlessness, altered sensorium, convulsions, tachypnea, repetitions on examination, hypoxia in ABG analysis, infiltrations were seen in chest x-rays, and among them, except one, all of them need some ventilatory support. So they had thrombocytopenia, bradycardia, hypotension, autonomic instability. All these features were there, but I would like to emphasize that fever was present in 100%. So this has to be seen. And when we did a zero surveillance of about 300 odd people who has been in close contact with the patient among the family members as well as the healthcare workers, only 2 were detected to have IgG positivity and IgG as well as IgM, and it showed that there is unlikely that asymptomatic positive illness in patients with Nipah. So most of the time, even in contacts, if they are not symptomatic, they are unlikely to have the illness. And this is our experience in this year's outbreak as well. These were some of the unusual or interesting manifestations, especially Transcriptase palsy, cerebellar dysfunction, bilateral ptosis. This is from the 2018 epidemic. And the most important way they come is syndromic presentations like encephalitis plus ARDS or encephalitis plus ARDS plus myocarditis. Such sort of presentation, when it comes to the casualty, we need to be alerted. And this sort of present, but it is very, very difficult to send all these cases, because in a busy tertiary care center, we may be seeing 3 to 5 cases or more per week. So I would like to take you through the challenges, identification of this sort of symptoms. And when we have such an illness, what more important was in a busy tertiary care center, if we have one such patient, we need to know which are the hospital contacts at that time. So proper hospital record maintaining is very, very important. Then only we will be able to list the contact easily, especially if the patient comes to the red area. We need to know red area timing of this patient and who all visited that, who all visited in the same vicinity, who all visited in the X-ray area, CT area. So this sort of documentation and this sort of maintenance of data is very, very important, so that we should be able to do the proper data collection and contact tracing. So this I have emphasized, but one point I would like to do is lab safety. There is a proper procedure for triple layer packing. I have not to explain to this group, because we are doing it for COVID-19 also. We need to know how to do the proper packing, but more importantly, we should be documenting every details in the sample collection form as well as on the box, because we need to know if the patient is in the contact list. If the patient is in the contact list, what is the type of contact, high risk or low risk, and if the patient is symptomatic or not, and either the patient is in a symptomatic, or if the patient is being sent because there is no epidemiologic link, but the patient is having classical symptoms of ARDS or myocarditis or encephalitis sort of presentation. So all these challenges are really different in an illness like Nipah. We need to implement infection control practices, and we need to emphasize uniform standard care for everyone, because in an ICU where the people are all in PPE, and we are using all equipments like ventilators, ABG, and transport ventilators, and all sorts of things. So we need to ensure that everyone gets the same standard of care, so that we will be able to give at least good outcome in at least some of them who are really going to be sick. And another important thing we have been going through for some time, safe burial in a dignified manner. This issue causes a lot of issues, so we have to be focused on this. And that we did last time also in COVID also we are providing to a larger extent, but it is all the more important, the psychosocial problems, especially when they are in isolation. So this has to be emphasized, and we need to plan the long-term follow-up. So this is about Outbreak 2018. Now this is one case that we have seen in Kochi. Patient was managed in Aster MIMS itself. It's a one patient, 20-year-old male, came with fever, headache, altered sensorium with the encephalitis-like picture. And system promptly alerted in 2019 also. There was proper training, setting up isolation facility, contact tracing. How 2018 was different from, how 2019 was different from 2018, because that time National Institute of Virology, Pune has set up a point of care lab during that outbreak, and that has started testing samples. So that way, it helped us in improving our early diagnosis when an outbreak happens. Because what is more important is if a person comes with similar symptoms, we need to rule out Nipah at the earliest. And especially in encephalitis, ARDS like presentation, those cases may be malaria, those cases may be other viral encephalitis, those cases may be bacterial meningitis. So we need to know what it is so that the system will be promptly alerted, and we have an added advantage of point of care lab. We have started in 2019, and that time also there were 30 contracts followed up, and there was 30,198 people trained at that time. This is 2019 May, before the COVID, which started in 2019 December, and we all been into complete training. The entire state started into PPE and other training for the COVID. From the entire 2020, we have been so geared up to tackle such illness. Now this is 2021. We had one boy, this is a 12-year-old male, came with high-grade fever, headache, vomiting, worsening sensorium, and later patient developed an episode of seizure. Patient was intubated and transferred to the private hospital, that is Aster MIMS, and from there patient was treated. And this patient also had infiltration chest X-ray, CT showed brain edema. The point of care ultrasound we did and receiving in the emergency department of our institution was normal at that point in time, but I was told it was abnormal towards the end of the symptoms. So this sort of a presentation, and this patient also had the myocardial dysfunction and later needed inotrope support as in the case. But this patient succumbed to the illness, and this patient came to us about an illness of about 4 to 5 days or so. And before that, patient has gone to a local facility, other two private hospitals, and then came to us, and then get shifted to the MIMS, and the patient samples were sent and diagnosed. And this is how this case evolved this time. So when this happens, we need to be alerted all on a sudden, and the meetings happen and the system is geared up, and we know that the entire system is tuned for that, because this involves proper training, especially in infection control practices, management of positive cases, management of people having symptoms, and we need to ensure that all high risk cases are in our high risk and low risk are in our contact list. They need to be followed up morning and evening with telephonic calls, and they need to be shifted if any of them develop symptoms. And we need to do a bat surveillance, animal surveillance. We need to find out how it happened, what is the cause for this illness, and is there are any new cases developing in the vicinity. So a lot of activities happens when we diagnose such a case in the system, and our system is so much alerted that this year also we had the same protocol and plans as we did in 2018 and then later in 2019. So I'm moving to the management part. So I've been just highlighting how this comes and how we can pick up more faster. I don't know, we need to be geared up so that we will not miss such cases, but it is not that easy, especially when we see more sort of more cases. But one good thing is, if you have a point of care facility, all suspected cases will be able to test after ruling other causes. That is what they say. But in real practice, in clinical situation, we need to rule out this first before going into other investigations, so that all the healthcare workers can be protected. So we now we know to the management part. We know that there are no vaccines. there are no definite diagnosis treatment for this. But one thing is very, very important. We need to strictly adhere to the intense supportive care, that is ABCDE approach. So case definition, this is a suspect Nipah case. That means person from an area or locality affected by a Nipah virus disease outbreak, who has acute fever with new onset altered mental status or seizure, acute fever with severe headache, or acute fever with cough or shortness of breath. And this is how we put the suspect case. Probable case is where the death has happened, like a suspect case who resided in the same village. By the time we identified the index case, we know that one person has already died in the same village with similar sort of presentation during the outbreak period, who died before complete diagnostic specimens could be collected. We put it as probable Nipah case. This is more of an epidemiological importance than the clinical importance, because a clinician will never see a probable Nipah case. So suspect case patients who came in direct contact with the confirmed patients in a hospital setting during the outbreak period and who died before complete diagnostic specimens could be collected. So this is the epidemiological definition of probable Nipah case. And a confirmed Nipah case is obviously a suspected case who has laboratory confirmation of Nipah virus infection, either by RNA identified by PCR from throat swab, urine, serum, or cerebrospinal fluid, or virus culture. Virus is cultured, but we usually do is the RNA identified by the RT-PCR test, and this is being done now also. So this is what I have been mentioning. Suspect Nipah case, a person in the locality, and usually this time also we have put an circumference of about 3 kilometers from the patient. If we have it, we have been testing specifically if they report with this sort of presentations. Probably they have a definite history of contact but died before we get a sample confirmation, and confirm it is obviously with the test positivity. So, but we have a lot number of cases in the contact list. We will be screening them closely, and all of them will be tested for Nipah virus infection. And only if so in our present outbreak, there is only one confirmed case, and that is the first index case. And now we move on to definition of a contact. A close contact is defined as a patient or a person who come in contact with a Nipah virus, confirmed or probable case in at least one of the following ways. So I don't think I have to list it because they come very closely. They share the same room. They use the be with the patient during the illness, including during transportation. They were in close contact with the deceased, suspect or confirmed case of Nipah virus at funeral or during burial preparation rituals without proper protection, has touched the blood or body fluids of suspect or confirmed case of Nipah, has touched the clothes or linen of a suspect. So all these are put as contact. And from this, we have to have a detailed history. Suppose something happens like this, and we say that there is a confirmed case of Nipah, we are going back to the same place, and we find out where this patient was, what is the entire course of illness from the day one of illness, and what happened to the patient till his recovery or death. That is how we track. And this is a very important way. This is a very important exercise in situations like Nipah virus, where there is a high human to human transmission. So this is there in our guideline also. This gives us a very clear idea what is a high risk contact and what is a low risk contact. High risk contact means any contact with body fluids, blood, urine, saliva of a confirmed case of Nipah. Any contact with body fluids of a probable case who died without a lab confirmation of Nipah, or spent time in close proximity and close space for more than or equal to 12 hours. This is one of the definitions, and NIE also helped us in last 2018. Based on this, we did the zero surveillance along with NIE. But some people might ask, what is so about this 12 hours? Why can't it be 6 hours? I may not be able to give that answer now. Maybe we need to know more about in this set of definitions. And low risk, any other contact such as touching, contact with clothes, linen, or any other item used Like people might be going for changing the oxygen, people might be seeing the x-ray near to this, and all sorts of things might be happening. So this is also known as low risk contact. So we need to see who all have been in close association with this patient. It could be healthcare workers, it could be patient's relatives, it could be family members, it could be a patient lying next to this bed, his relatives, and all those things will be collected in detail. Where the patient has moved, patient might have moved for chest x-ray, so the patient before after this patient's chest x-ray, who were again in the room, who were in the path, all these things will be included in the contact listing, and it's a good exercise. And then we decide what is the high risk contact and what is a low risk contact. High risk contact, uh, actually what we understand now is Nipah is infective when the patient is symptomatic. So this is the understanding currently goes from the previous outbreaks and our experience with the 2018 illness. So if you the patient is a contact is not symptomatic, even if high risk, we will not be able to test this virus from them. And we have tested many high risk contacts also this time. All of them came negative. But whenever a person in the contact list develops symptoms, we need to shift them immediately in the proper isolation facility, ambulance, and all those things. And we need to keep them in the isolation facility, and they should not be allowed to mix. If a person in isolation, it will be a separate room, and everything should be provided there. And if any of them, even in a low risk contact, develop symptoms, especially fever, we need to shift them and manage appropriately with the test and then see what it is. But in this time, the major challenge was when some of them at least were having COVID-19 infection along with them. And that has created a problem in identifying the symptoms, because the symptoms are actually fever, cough, upper respiratory symptoms, and this is having for both the illnesses. So once we do the contact listing, we have a disease happen like this patient, and we did the contact listing, and we keep the contact list and telephonically call them. And those cases we cannot keep in isolation at home. We will be shifting them for institutional quarantine, and that is strict room quarantine that we are room isolation that we are advising. So all patients having fever must report to fever triage, from where they will be sent to the isolation facility. So triaging is very, very important in this situation. How it is being done? If the person in isolation, if an patient reports fever, we need to shift them. And from the triage, we do the assessment and see whether the patient comes under the risk category that we have been discussing about. And then we divide them. Is a contact with symptoms, or it's a suspect case, and then we identify and admit them and start the investigations. And if the person tested positive, patient will be so, otherwise we'll be continuing the isolation period, treat for other causes. And then the total isolation period this time also we have kept as 21 days from the onset of contact, if they do not develop any symptoms. So triaging is very important. This is how we did last time, but it is important to know how it is being done. So in the emergency department, if a person comes with fever, we should not be moving into the main triage where the other diseases like CVA, CAD, or trauma, everything be handled. So if the fever, it should go to the fever triage. So this we have been managing, but I have just emphasizing in the context of Nipah. In the fever triage, we need to take the history. Detailed history will tell you if there is a case definition of NIV is and the contact history is there. If it is satisfying, we need to send the patient to isolation. Along this, we will be sending the patient for the investigations also will be sent. And if the person is in seriously ill, patient will be managed with strict infection control practice in the ICU, or otherwise patient will be shifted to isolation ward, and we will be deciding how to go about with the research. But all the other investigation tests must be restricted if we cannot ensure proper infection control practices. First rule out Nipah and then look for other causes. But all basic basic care management is needed. Suppose we suspect meningoencephalitis, we will be giving antibiotics, antiviral like a cyclovir, anti-edema measures, anticonvulsants, everything we'll be giving, but we will be doing other management, specifically shifting the patient to risky areas or to the ward only after ruling out Nipah. And I would like to go through the SOP for lab investigations. This is what is happening now in Kozhikode. we have three types of cases. One is epidemiologically linked symptomatic cases. That means the person is in our contact list, high risk or low risk, and we report symptoms. That is the epidemiologically linked contact symptomatic cases. We have a point of care lab, but all epidemiologically symptomatic cases we are sending now also to ICMR and NIV Pune. But epidemiologically linked asymptomatic cases we are testing in our own institution at the point of care lab, and epidemiologically unlinked but suspected cases like those coming with encephalitis, ARDS, or myocarditis, especially from the in the close association with the patient. So that is also being done in our own institution. Which are the samples collected? The oropharyngeal and nasopharyngeal swab, and it's usually preferred that we take both the swab, but we can be put in the same viral transport medium, blood and serum in separated gel tube, and urine in sterile universal container. And CSF, if we are doing it, we will be collecting that also, and all those will be put in triple layer packing, and then with the appropriate ice pack and packing will be done, and the box must be labeled appropriately so that they will know what is the sample inside, whether it is epidemiologically linked or not, what is the, because this is a very highly secured, this sample has to be sent, it is considered as a biohazard if we do not handle it appropriately, both for the people who handle it as well as those who test the samples. Management, I've already discussed in brief when we discussed the 2018, but I'll just take you through. It's ABCDE approach: airway, breathing, circulation, disability, exposure. We need to plan for appropriate care, including intensive supportive care, even from receiving the patient in the triage. Fever triage, suspect Nipah, we have to manage them and shift them. If the patient is desaturating, we will be shifting to ICU, but with proper infection control practices, we need to manage. So the management is most important step in a disease patient is actually intensive supportive care. But we have some more drugs and we have some experience with using these drugs, but evidence is not that strong. But we have remdesivir, which we have been using for COVID for quite some time. And we know that it's an investigational nucleoside product at adenosine analog, RNA-dependent RNA polymerase, inhibiting viral replication, and this is also being tried as in Malaysian and Bangladesh genotypes of Nipah in vitro. It's not in patients. So this dose is the same as we have been using, 200 milligram loading dose IV followed by 800 milligram IV once a day up to 12 days. But we know what are the what we should do, because we have been using for COVID-19. We need to do for the EGFR. We need to see the LFT. If the LFT enzymes are more than 5 times, we should not be using this. And the other important message is we have the same drug listed in our protocol in the same dose for post-exposure prophylaxis also, because we have a high risk exposure, and without proper PPE, we can advise them on this drug. The other drug we have in the protocol, and it has some use, because this is also a broader spectrum of antiviral activity of the favipiravir, but it is originally came as an influenza drug, and it has also shown that in vitro it has been shown that it inhibits Nipah and Hendra virus, and the dose is 1800 milligram BD on day 1 followed by 800 milligram BD for next 13 days. It's the same dose. We were using about 10 days in COVID-19. It's the same is done. And post-exposure prophylaxis also, this drug is included. Next drug is ribavirin. Ribavirin, in fact, we have given in 2018 outbreak also for about 10 patients. For those who have survived, we have continued the dose, but others we have given for limited days. And the dose is 2 grams stat, 1 gram 6 hourly for 4 days, followed by 500 milligrams 6 hourly for the next 5 days. This is from the WHO guideline for hemorrhagic fever that this dose is incorporated, and this is used for NIV infection. And ribavirin adverse effects, there are not much major adverse effects, but we should be looking for hypersensitivity, hemolytic anemia, teratogenicity, and all sorts of things are there. But we have to monitor closely the hemoglobin and LFT. And the other drug that was very much talked about this time also is monoclonal antibody 102.4. and it recognizes the G envelope protein and appears to block the receptor binding site on the protein and prevent the virus entering into the host cell. But this has to be administered sufficiently early, as we do in monoclonal antibody for COVID-19. And even they have already suggested for post-exposure prophylaxis also. But though we had this drug in 2018 and 2019, but we have not used it so far. So there are protocols and guidelines, and it was we have to have a consent also for using this drug. So we have to appropriate institutional ethics committee approval and guidelines for using this drug. And we need to emphasize on standard care for encephalitis. We need to control the intracranial pressure. As we do for management for pain, control of cough, other symptoms, but avoid NSAIDs. That is why we say clear message that we give for all infections. It is important for here also. Prevention of seizures, control of systemic hypertension, and elevation of head end for 30 degrees. All sorts of intervention that we do for raised intracranial pressure can be used here. And we can use drugs like furosemide, mannitol, of brain edema. And if the patient is deteriorating, obviously we'll be going for IV sedation and mechanical ventilation. Seizure, we start with low reservoir start dose of posphenitoin or phenytoin, which is available, or levetiracetam. All these levetiracetam we are using in even otherwise for encephalitis. And we know how to manage myocarditis by, if you have a point of care ultrasound, it always very rewarding in intensive care unit. And I believe it might come as a, or even replace our stethoscope, because it is more handy and more widely used nowadays. So this will give us an idea of the myocardial contractility and how this patient will fare. And ECG is always a very supporting tool. And we can use drugs like dobutamine or norepinephrine if the blood pressure is low, like less than 70. So those things we use, and I don't have to elaborate because we use it, and the dosage is showed in most of the ICU, so we can do it accordingly. And ARDS, standard care of ARDS as we do, and we are doing it nowadays with non-invasive ventilations and appropriate mechanical ventilations. And we know which are the contraindications for NIV, like diminished level of consciousness, vomiting, upper GI bleed. All those cases we may be going straight away going for intubation. And also we need to look for hemodynamic instability, agitation, all many things we have to manage. And proper management of ARDS also, as per the advice of the critical care team, is also important, as we do in COVID-19. This is very relevant in the case of NIV, Nipah virus infection also. So this is the treatment algorithm, and we will just go through it. We have a case with a history of definite contact and symptoms. We need to emphasize, we need to assess what is the condition of the patient, go for intensive supportive care. And this is what I have been discussing. It's general measures, treatment of encephalitis, ARDS, and myocarditis. And if the patient is improving, we can do a repeat test. If the test positive, it is confirmed case. And if the test negative and symptoms are continuing, we need to do the repeat test after 48 hours in all symptomatic patients, because patient may be negative in the initial period. This we have emphasized on our guideline, because in 2018, we had a patient came with fever and mild upper respiratory symptoms and loose stools. Patient was initially tested negative, but after 3-4 days, the symptoms went persisting and patient later turned positive. So we need to have a repeat test in all suspect cases and symptoms are persisting. This test positive, we have the confirmed case, we need to shift them into appropriate isolation facility till, and we can manage intensive supportive care, continued, and we can decide on drugs like monoclonal antibody if it is available, or remdesivir, favipiravir, or ribavirin. And monoclonal antibody, the protocol we have to set up, but I don't think we have it. We might, if there, luckily we don't have any more cases now. And drug dosage I have already given. We can use remdesivir, favipiravir, or ribavirin. And if the patient is having test negative but symptoms persisting, we'll do the repeat test. But till then, we have to continue the supportive care like treatment of encephalitis, ARDS, and myocarditis. This table is added this time. What is the change from 2018? What we plan managing is we have added remdesivir, we have added favipiravir, because these two drugs were at that time were not available. And now we have this table also, that is post exposure prophylaxis. If there is a definite exposure, especially without proper PPE or breach of PPE, we can advise on injection remdesivir 200 milligram loading and 100 milligram daily for 12 days, or favipiravir 1800 mg for day one, the same dose as we use for the treatment. So if the patient is having a Nipah suspect and they tested positive, patient is in isolation ward, and we do the RT-PCR and the test negative, but the patient is in the contact list, we should observe the patient for 3 days. And if the patient is asymptomatic, we can discharge the patient, but the contact list once discharged, we will be observing at home for a maximum of 21 days. But symptomatic patient, we do the repeat test, and if the test is negative and asymptomatic, we can do this, and patient will be at home care. And but always we do 2 tests. That was what the protocol we did in Cochin also, but we don't have to do it because we don't have a cases as of now. And we have already discussed the treatment guidelines. And if the patient is tested twice negative and we have excluded Nipah and the symptoms are persisting, we need to do we need to look for other causes. And infection control practices, PPEs, all those things we have discussed, and healthcare workers, contact tracing. And we have also emphasized the importance of body management, and disease needs the same way, the dignity and the respect we have to provide, and it should be appropriately done, and it has to be. But the other important point I would like to emphasize on the psychosocial aspects. We have done 2 studies in 2018. That was a qualitative study on the psychosocial impacts of Nipah survivors. We have 2 survivors, and that those who are being in quarantine during the Nipah outbreak. And there was a lot of stigma in the society, psychological sequelae experienced by healthcare workers who were managing these cases. And there were a lot of public mistrust and confusions. It is still happening this time also. And even there were saying that this was a creation by the healthcare system. This time also we are getting this sort of communications. And this is another one we did. It is relevant for COVID-19 also, to understand the psychosocial impact for May, June 2018. There were many of them were not very sure why they were in isolation, and they were thinking that it's for the protection of their families or self-protection, or sorts of confusion were existing. And they were all experienced fear of during stay in isolation. They were saying that we have contracted Nipah for even with no symptoms, they were actually having anxiety and fear, worry. So we need to give a lot of psychosocial support to them. So I've been taking you through the 2018, 2019, 2021 experience. And these sort of outbreaks are not unusual, but outbreaks with human to human transmission. COVID-19 has trained us a lot, educated us a lot, but we need to stick to the strict infection control practice. We should not be lenient in it. And we have to always adhere infection control practice. And I believe in future we should be continuing the use of mask in casualty or emergency department, and you will be using so the same sort of precautions, hand wash and hand hygiene and sanitizer use, so that we can do as a teamwork. And one health approach is also important. We cannot alone manage this, and we need to do a lot of support from the entire system. So thank you so much.
Why long-term follow-up needed for survivors? That is one question.
Long-term follow-up is needed because we have very few reports, and some of them showed that they have relapsing encephalitis. They have some neurological manifestations. So that is the reason we advise long-term follow-up. Not like COVID-19. There is nothing related to respiratory symptoms, but it is more related to the neurological sequelae. That is identified in some of the cases. So we have been following our own two survivors also, but so far they have no symptoms.
Can a patient be positive for COVID and Nipah simultaneously? Should we screen all patients with this presentation even if they are positive for COVID? Because some of these symptoms are all.
That is what I am going to say. That this was more challenging this time because the contacts, if they have fever, we bring them to the isolation facility. But we know that most of them are having COVID nowadays. So, but even if they come with definite symptoms of COVID positivity, we have sent for RT-PCR Nipah. And if the symptoms are persisting after 48 hours or any new symptoms are developing, we are actually sent to repeat tests for Nipah because these are close contacts of the patient. So to be on the safer side, this can coexist. This question came only because we are in the COVID-19. We should not be suspecting in all cases because it will be very challenging. And in fact, the protocol says we look for the common things always.
Yes.
But we know that if there is an illness happening in a busy casualty, red area and all, it will be very challenging also. So we need to know that how we should protect ourselves, how we should protect other patients in the emergency department, how we should protect other healthcare workers in the. So now we have learned a lot because of COVID-19. And that's what I was saying. If we continue this practice of using the masks and sanitization and gloves and other things, maybe to a larger extent, we will not be seeing that more people are affected with such patients coming to the busy casualty, because we can't do this test in every patient because that's as I have told, 3 to 5 cases might be there, but there are some situations we must suspect like autonomic instability, but usually it comes towards the late case. So one case diagnosing is always a challenge. And more than that, if there is another challenge for clinician. If we suspect Nipah, we should isolate that patient at least till the results come. Okay, so that is also we need to remember. But always infection control practice should be on the high end.
What is the status of 2 survivors of 2018?
They are doing good. In fact, we were supposed to see them, but because of COVID-19, we couldn't see them. But they are doing good.
Is Nipah encephalitis or Nipah pneumonitis having more incidents? Only we are having a few number of cases.
But the usual combination is ARDS with encephalitis. But we look for encephalitis alone. Okay, but if we look for myocarditis by ultrasound or tropi or ECG changes, these cases we have been seeing in some patients also. But I would suggest if this combination, we have to be more careful, especially respiratory secretions, vomiting, and that has happened in our first outbreak also. There is a more chance for spreading the illness. So we have to be more careful. Now we know COVID-19 and Nipah, but we also know that there are many other viruses, many parts of the world. And Kerala is a small place, but we get visitors from across the globe very often.
Earlier, seasonality of infection was mentioned during December to May, but now it is reported now. If any reason we are expecting?
That we don't know. In 2018, we were also told that it's during the breeding season and when bats get excited, and all sorts of hypotheses were given by the specialists in bats. And they excrete in, but the one thing they were saying, it's a very, very rare chance occurrence. Bat excretes the virus and a person is there at the same moment. So this is very, very unusual combination to happen. But we should tell our children to, when they should not be playing, when they play so very close to this, handling these things, we should be more careful. And in fact, the person who has visited the area, she told me that she felt the same type of locality what was there in the other case also.
Are Nipah survivors more prone for other viral attacks like COVID, etc.?
I don't know. We have only very few survivors. I have not looked into in that way also.
How many days quarantine is needed for healthcare workers? till
So
the results come.
now this we have discussed this with many experts, and currently we are recommending 21 days from the day of contact. But the maximum in risk of infection is for the first 14 days. But we are being more on the vigilant side because we have only one case, and we were actually not knowing, especially with the last year's experience. But luckily, we don't have any further cases detected so far. But what is the recommendation for this at present is 21 days, and I think it's already 11 days.
After how many days of fever onset does features of encephalitis, myocarditis, and ARDS appear? Is there any early sign that can be elicited clinically that leads to the early diagnosis?
It's very important.
Relevant.
And very, very relevant also, because people in IIT and other areas, they were trying to design some algorithm or some AI based device. And I said it's a very unusual disease. So it is very difficult to suspect. But my message is, if we have this sort of combination and we don't find out any usual diagnosis, we need to suspect, especially there is a chance for contamination with the bitten or eaten foods, or they have gone for some exotic outing and other things, and patient comes with sort of illness. We need to be vigilant. And one important thing might be, I believe this system in Calicut will continue of this point of care testing, and Alapi we have a lab. So these two labs might be helping us in a larger extent. If we have a similar suspicion, we need to get the samples appropriately collected and packed and transferred to this center and get tested fast, so that we can rule out Nipah in situations. And I don't know whether there are no symptoms or signs that will tell in the early cases. And usually in any other viral encephalitis, by 5th day or so, patient develop features of encephalitis, seizures.
Likewise, in any case of fever, we'll have to watch for these features of encephalitis in the first week and by the end of first week.
But it is very challenging, especially if you are working in smaller places, PHCs, this sort of presentation. But COVID has taught us a lot with regard to infection prevention and control.
So we are more sensitive now.
And we should not forget it. But COVID has made us so very light also. And even in Kozhikode, I don't see that sort of fear.
Panic.
Yeah. Maybe death has caused so much of panic last time.
Does oseltamivir have any role in Nipah if given in post-exposure prophylaxis?
No. If there is only if we suspect influenza, otherwise no.
Shall we conclude that all acute encephalitic syndrome presentations to be investigated for Nipah that we have already answered? Because if we are having a primary case, or if the place is so much important, or if we are not getting any, in the primary care setting, we need not plan for any investigation for Nipah. If we are seeing any symptoms of encephalitis and we are having a child or a patient with 4 or 5 days of fever, then we need to refer the patient with proper reference letter, in which we have to specify that we are suspecting all these things because the encephalitis is like that. Then the secondary care or tertiary care center people will get an idea. They'll fast track the patient and can isolate the patient like that. We should always think that syndromes, encephalitis, ARDS, myocarditis, such sort of combinations, especially in young, we have to be very, very careful. And now we know how to go with the infection control practice. So we should be protecting ourselves also when dealing such patients. Any chance of cross? This is an independent question. This is not related to Nipah, I guess. Any chance of cross immunity with COVID infection or COVID vaccine, both being RNA virus with similar clinical presentation? I don't know. Somebody was saying there is a report. I have not read it. You have to find out. Somebody was saying there is a suggestion, but I have not gone through it, in fact. We don't have enough sample size to commit. But people are getting COVID-19 among this, but it's as proportionate to the COVID-19 infection we have in Calicut community itself. Shall we include Nipah in CSF studies and to viral? That all again we have told that not in all cases, not in all districts, not in all emergency department, but we need to keep everything in our mind because Nipah is one among the DD of in viral encephalitis as of now. Not only viral encephalitis, viral ARDS, viral myocarditis, everything. Which all diseases should be ruled out in acute encephalitis syndrome?
Acute encephalitis syndrome, usually we think of Japanese encephalitis, herpes, or then what is that? Many of the time we don't get a definite cause for the encephalitis. And always, it's not only viral, we should be thinking about malaria, treatable causes, meningitis, all those presentations we have to be knowing about it. And in the other thing we always suspect is autoimmune encephalitis. So we should be keeping our this open so that we will include all those things in our differential diagnosis. And as said, it's always not very easy to rule out Nipah. But in situations like autonomic instability, seizures, and neurological manifestations, eye movement problems, and all sorts of things we might suspect. And in such situations, definitely we should be looking for this. But it is always very challenging to diagnose with the first case for the clinician. And once you diagnose, it's always more challenging that we should identify there are no similar deaths at that point of time. So if something like happens, we need to investigate all the encephalitis ARDS presentations that we have seen during that 2 weeks or so that we will not miss any primary case. The index case need not be the first case that we have detected.